Hello everyone, welcome back. And for the moment, we're going to take a fairly abbreviated look at how ultrasound can help us in the patient who's in shock. I will just point out that most of the time we're not as good as we think we are at identifying the reason for shock. Sometimes the history and physical exam may be pretty clear, but there are other times where we have the undifferentiated shock patient where they start to become altered or have hypotension, and we're not 100% sure why. And ultrasound can help us quickly and accurately identify the etiologies, the physiology of shock, and help us avoid errors and keep patients safe by not making the wrong decisions. And just to start off the framework of the discussion, we have to remind ourselves that there are 4, sometimes 5 basic physiologies of shock. The primary 4 we all know: cardiogenic, hypovolemic, hemorrhagic, which is one category, distributive, and obstructive. Some folks will throw in this endocrine category as a reminder that maybe we should check a cortisol level and a TSH. But really, 4 physiologies with maybe the endocrine one thrown in as well. And so when we have the patient in front of us who's in an undifferentiated shock state, combining the history and the physical, then we can add the ultrasound to answer, really, if we can answer 4 basic questions about the shock patient, we will be much more accurate and be able to solve what our next management steps are and what the next steps in the workup are. And there's really 2 questions about the physiology and about specific etiology. The first couple of questions are, is this an obstructive process? Is it cardiogenic? We can usually answer that all by looking at the heart, the IVC, and the lungs. Maybe we don't even need the lungs, depending on the clinical scenario. And as far as etiology, essentially, if we've decided, wow, this looks like a hypovolemic shock, then we want to look to see if there are some obvious signs of a bleeding source or an infectious source that we can start to target our treatment and workup for. And we can usually, again, this depends on and is guided by the clinical scenario, but we may be looking at the aorta for a ruptured AAA as a bleeding source, just looking in the abdomen for hemoperitoneum. And this could apply if there is trauma, if there's occult trauma that we don't necessarily know about, or in the case of maybe a ruptured ectopic, where we're looking for free fluid in the peritoneal space. And then the others, again, guided by the clinical scenario and the other findings. If we think it looks like a distributive shock and we think it's a septic shock, then we may look at, there's a red area on the skin, and we'll look to see, is there an abscess that needs drained, or is this a necrotizing infection? If we have findings in the history, physical, and the cardiac ultrasound that suggest PE as an etiology, then maybe we're going to look for a DVT to help us add data to that. So all of this is driven by a good history and physical first. Then we add ultrasound to help us clearly define the physiology and the etiology. And what we look at on ultrasound and how we interpret the ultrasound is all driven from the history and the physical to begin with. So like we talked about, these are the big etiologies: cardiogenic, hypovolemic, hemorrhagic, distributive, and obstructive, and then throw in endocrine. I want to go in to mostly what causes these. We know cardiogenic is usually pump failure, although there may be some mechanical cardiogenic etiologies of shock. We won't talk about those in a lot of detail. Hypovolemic is, we got to think about blood loss or maybe fluid loss. Blood loss is the one you don't want to miss. Distributive, usually that's either anaphylactic, neurogenic, or septic. And then obstructive is usually cardiac tamponade, pulmonary embolism, or tension pneumothorax. You could even maybe throw in abdominal compartment syndrome as well. And endocrine is truly a mix of all these other physiologies. A lot of times it's going to be distributive and or hypovolemic, and really that's just a reminder to check cortisol levels and TSH in your undifferentiated shock patients. So I'll just point out, all of these ones highlighted red are things that we can directly identify with point-of-care ultrasound and help us quickly define the physiology. So let's talk about the findings a little bit. So in cardiogenic, most of the time we're going to see poor left ventricular function, although don't forget, we may see some things where there's acute regurgitation due to aortic dissection or endocarditis, or papillary muscle rupture, or ischemic ventricular septal defect, left ventricular free wall rupture. So there are other mechanical things. They're certainly much less common than just straight out pump failure as a cause of cardiogenic shock. But don't forget that they do exist. Hypovolemic and hemorrhagic shock, most of the time what we're going to see is a small collapsing IVC. We're going to see probably a vigorous heart, and then we may look for specific etiologies like hemothorax, hemoperitoneum, signs of a ruptured AAA. And remember, hemoperitoneum may not just be in trauma. There are spontaneous causes. and ruptured ectopic is another big one. So outside of trauma, other reasons for hemiperitoneum. With distributive shock, we're going to see the same thing with the heart and the IVC. It's going to be a collapsing IVC. The heart's going to look vigorous. Now, if we have the history and physical on top of the ultrasound, then we can start to decide what's the etiology of this distributive shock. Is it septic shock? If it's anaphylactic shock, hopefully some other history and physical clues have keyed us into that, as well as neurogenic shock. Hopefully, if it's neurogenic shock, again, there are other history and physical findings that help guide us in finding that etiology that goes along with the physiology. With obstructive shock, cardiac tamponade, that's going to be a direct diagnosis that hopefully we can make with ultrasound. If the patient is in shock due to a pulmonary embolism, they are going to have a dilated right ventricle. There is no pulmonary embolism causing shock without a dilated right ventricle. So if the patient's in shock and they do not have a dilated right ventricle, the etiology of their shock is not PE. And then tension pneumothorax, we can readily identify with ultrasound. And again, there's going to be clinical clues, right? The patient's probably going to be short of breath, tachypnic, probably hypoxic. So again, incorporating all of the history and physical data with our ultrasound on top of it. So we're going to do this again to rapidly narrow the differential, figure out the physiology, and then direct our next decisions. What's further workup going to look like? What treatment are we going to start now? And then what kind of disposition decisions are we going to be making? And the easy thing is, if it's not cardiogenic, it's not obstructive, then we know probably the first thing we're going to do is fluids and or blood if we think they're bleeding, while we think through the rest of the case and work up the rest of the patient. So things you always want to look at. You pretty much always want to look at the heart and the IVC. And then I put always the aorta under always, although that depends on your scenario and the setting. If it's a 22-year-old female, then probably the ruptured abdominal aortic aneurysm is not their etiology. So depending on the scenario, we'll say we could move that aorta over to the depending on the scenario. But we're always going to look at the heart and the IVC. Everything else kind of depends on the scenario. If they've got respiratory findings, we certainly want to take a look at the chest to see if there's pneumothorax, if there's interstitial fluid, if there's pleural fluid. If they have the right clinical scenario, then we probably want to look at the abdomen for signs of fluid or bleeding in the abdomen. Think about ectopic. If we looked at the heart and we think maybe a PE is the etiology, then we could double check wherever we think there might be a DVT. Maybe it's the legs. If they've got a PICC line in their arm, then maybe it's the arm. But we can look for DVT to help add weight to the potential PE diagnosis. And then if we've decided, okay, we think this is distributive shock and we're worried that this is septic shock, a lot of times we can find the source of infection with our ultrasound by looking in the lungs. Maybe we see their pneumonia. Maybe we see obstruction because they've got a complicated urinary tract infection. Maybe we see a nasty looking gallbladder in the abdomen or some other inflammatory change that is the source, their septic source. And if there are areas in the soft tissue that look concerning and we're worried about infection, then obviously we'll look at those. So we can identify septic sources. In most patients, actually, the literature would suggest patients with septic shock, if we look at all the right spots, we can find their septic source about 85% of the time with ultrasound. But that's all going to be driven by the history and physical. We don't just want to randomly shotgun and ultrasound every single body organ system because that would not be very efficient. We're going to use the history and the physical to guide us. We're always going to look at the heart and the IVC, and then the clinical scenario will guide what are the next pieces that we want to look at to help us define their etiology of shock. So with that, that's going to introduce us and bring us into looking at echocardiography, because the heart is going to be one of the most informative and most important organ systems for us to examine in our patient in shock. And I'm just going to point out, I'm not going to review image acquisition, how to acquire images, what the normal anatomy is, because I'm expecting that you'll know that, and that's review, and we're going to practice that in the hands-on session anyway. So we're going to talk straight into some of the pathologic findings. And the first one is something you would see in obstructive shock, which is tamponade. And tamponade, essentially fluid around the heart, and when it's severe enough to cause shock, we should see collapse on the right side of the heart. And the first place we'll see is collapse of the right atrium, but then as it progresses, we may see progressive collapse of the right ventricle. We will also see loss of phasicity in the inferior vena cava, and we'll take a look at some of that. But here's some examples of cardiac tamponade where we see these large, pretty sizable pericardial effusion. There's also a pleural effusion back here, and this right ventricle that can't even expand during diastole because there's so much pressure on it from this effusion. Again, pretty large pericardial effusion here, and then the right ventricle being collapsed, we can see some right atrial collapse as well. In this example, we can see it looks like someone's poking their finger into the right atrium, and that occurs during systole. Same thing here, we can see collapse of the right atrium. This is an early finding in cardiac tamponade. Now we're going to use our ultrasound findings in the entire clinical scenario to help us decide when and where we need to perform pericardiocentesis, because the ultrasound findings sometimes occur before the actual clinical findings of the patient progressing into florid circulatory shock. A few other examples. Here's some collapse in the right ventricle, pretty large pericardial effusion all the way around. And here, this is the right atrium. This right ventricle can't even fill during diastole because there's so much pressure. We have large pericardial effusion here as well. So these are all signs of RV collapse, and these are signs of tamponade. There are a few other findings that suggest tamponade physiology. I'll point out here this left ventricle also looks compressed, and there are some findings with Doppler, but that's a little more detail than we want to get into for now. And then, as we'll see with obstructive shock from tamponade or from PE or tension pneumothorax, we will lose phasicity in the inferior vena cava. So basically the inferior vena cava will be distended and it will not collapse with respiration like it normally would, because the right atrial pressure is increased in patients with obstructive shock from any etiology. So the next cause of obstructive shock may be from an acute pulmonary embolism, where the main finding is going to be a dilated right ventricle. So here we've got our peristernal long axis view. We can see this right ventricle is much larger than it should be. Normally the right ventricle, the aortic root, and the left atrium are about equal thirds, but in this case the right ventricle is much larger, and we can even see it's compressing on the left ventricle. Again, here we see this is left ventricle over here. It's being compressed by this massively dilated right ventricle, and we can see the septum being pushed towards the left. This is the paradoxical septal motion of right ventricular strain, in this case from acute PE. Now remember, there may be some other more chronic etiologies of right ventricular failure, so as always, correlate this with the entire clinical picture. And if we truly think they have an acute PE causing shock, then it's maybe worth taking a look at targeted extremities to see if there is a DVT that will add weight to the diagnosis of an acute PE. Just a few more examples. Again, dilated right ventricle, compressing the left, this heart's tachycardic. And over here, this is not as pretty of a picture, but we can see a dilated right ventricle compressing the left ventricle. This is right ventricular failure. Again, we want to correlate this to decide if this is acute or chronic, and maybe look and see if there's an acute DVT somewhere that helps further confirm or increase the likelihood that this is an acute right ventricular failure. And other signs we'll see in the peristernal short axis view, we'll see a big dilated right ventricle compressing the left, causing what some call the D sign. So we've compressed the left ventricle and made it look like a D. Same thing, we can see this here. And if we even just see the diameters of these chambers, the right ventricle is dilated compared to the left, and this may be due to an acute PE causing obstructive shock. And just like we saw in tamponade with acute PE causing obstructive shock, we should see loss of the IVC phasicity. So those are the big causes and findings of obstructive shock. Remember, if they've got respiratory findings, look for a pneumothorax as well, because that's another cause of obstructive shock. Then the next big cause of shock is cardiogenic, and this is the top two we want to rule out with ultrasound. Is it obstructive shock or is it cardiogenic shock? So once we've looked for pericardial tamponade or a dilated right ventricle, or in the right scenario, maybe a pneumothorax, the next thing is left ventricular function. Do they have pump failure? And we're going to look at the size and shape of the ventricle, how it's squeezing, how well is that mitral valve opening, and how well is the endocardium coming together during systole. So in this example here, we see that mitral valve is opening nice and wide, and it's going up and slapping against the septum. Usually if we see that, then we know we have a pretty good feeling that the left ventricle function is pretty good. But then we can also look and we can see the endocardium comes pretty close together during systole. We see that change in volume during the cardiac cycle. So we know this is pretty good left ventricular function here. Here are some examples of poor left ventricular function, where the mitral valve barely opens. We see very little volume change during the cardiac cycle. Same thing over here. There's barely opening of the mitral valve. We don't see a lot of volume change during the cardiac cycle in this left ventricle. So these are cases of left ventricular pump failure. In peristernal short axis, we see similar findings where we just see this big circle pretty much stays a big circle throughout the whole cardiac cycle. So this left ventricle is failing. Same thing over here. This left ventricle doesn't change in volume very much. Now we do see some pretty good squeezing here, but not throughout the rest. So these are regional wall motion abnormalities that may occur in an acute MI or some other etiologies of cardiogenic shock. So we've got an example here of aortic dissection, which may be one of the mechanical causes of cardiogenic shock. Aortic dissection can cause shock in a few different ways. One, if they have acute aortic regurgitation, that will be a mechanical cause of cardiogenic shock. So they may still have vigorous left ventricular function, but they've got an aortic dissection that's causing regurg, and that can cause shock. So here's what we're going to see: a dilated aortic root. Maybe we'll see a flap here. And if we look in other parts of the aorta itself, we may see a flap. So here's a flap in this aorta in a short axis view. Here it is in a long axis view. Now the other way that aortic dissection may cause shock is it may extend into the pericardium and actually cause cardiac tamponade. So a couple of different ways aortic dissection can cause shock: through mechanical causes of cardiogenic heart failure with aortic regurgitation, or through obstructive shock when it dissects into the pericardium. So dissection, big thing on the list. You definitely are more accurate identifying this when you incorporate ultrasound early. And if you miss this, you're going to make wrong decisions and patients will probably die. So with bedside echo, we can look for and exclude causes of shock. And there are other things we can do with Doppler parameters, but let's not dwell on that for today. So the main things are: look and see, do you have signs of obstructive shock? Do you have signs of cardiogenic shock? Maybe there's aortic dissection, depending on the scenario, and nail down that physiology, and then you can start searching further for other etiologies of shock. So we talked a little bit about the inferior vena cava. All I really want to say about it, we kind of talked about the loss of phasicity that will happen in obstructive shock. We can also follow the IVC over time as an estimate and a serial measurement of central venous pressure. All I really want you to remember about this is if it's flat and it's collapsible, then the patient probably can handle some fluid. They don't necessarily need fluid, but they can probably stand fluid and tolerate fluid if they have a flat and a collapsible IVC. If the IVC is fat and doesn't collapse very much, then they've got high pressures on the right side of the heart. Now, it could be acute or chronic. In the acute setting, it could certainly happen from obstructive shock. It can happen from cardiogenic shock. But anything that increases pressure in the right atrium is going to increase diameter and decrease the phasicity of the IVC. So just seeing a fat IVC alone is not diagnostic of anything. It means you need to look further with history, physical, and echo to help you determine the etiology of that. So how do we get images of it? We're going to practice it, but essentially we want long axis pictures, indicator towards the head. So here's the heart, this is liver, and we see the IVC kind of cuts under the liver and enters into the right atrium. This IVC is flat and collapsing. This is either normal or in a patient who could tolerate some fluid. We can place an M-mode spike across the IVC to get measurements of it during the different phases of respiration to see how much it collapses, and there are even collapsibility indexes. I'm not going to get into a lot of that. And we can use some of these rough numbers to help us estimate central venous pressure. Again, these are all estimates, and we all know that central venous pressure is not a perfect indicator of whether the patient actually needs fluid or is going to be fluid responsive. So don't memorize these, just realize flat and collapsing means can probably take fluid, and fat and not collapsing means there's high right atrial pressure, and there are a lot of different etiologies of that. And it doesn't really matter if they're on the ventilator or not. It changes when the IVC changes diameter during the cardiac cycle, but whether it changes or not still may represent the right atrial pressure. So when you're spontaneously breathing, inspiration causes a decrease in the diameter. When you're on mechanical positive pressure ventilation, inspiration causes an increase in the IVC diameter because the physiology of respiration is different. But how much it changes still will help you reflect right atrial pressure. And that's all I really want to say about the inferior vena cava. It can help you. You have to correlate it with other data to help you make decisions around it. It's not a yes, no, fluids or not answer, and please do not use it that way. Let's talk a little bit about lung ultrasound, because like I said, in certain scenarios of shock, lung ultrasound can help us. And these are the reasons to do lung ultrasound: shock, chief among them, but also if they're just short of breath, they've got cough or other symptoms. And the things we can answer with lung ultrasound is, do they have a pneumothorax? Do they have pulmonary edema? Do they have signs of pneumonia? Or do they have a pleural effusion? And is it simple or complex? So, and we know this from a little bit from what we learned in the FAST exam already, so I won't belabor this too much. But pneumothorax, generally the main thing we're going to see is lack of lung sliding. So here we see there's rib shadows over here, and right here's the pleural line. There's no lung sliding. The whole lung is moving a little bit because the patient's moving, but there's no lung sliding here. And this little thing we see here is called a lung point. This is the most specific finding in a pneumothorax, we see this is where the lung is up right here. This is the interface to where that lung is down. So over here, we don't see sliding, and we see the lung kind of sliding up and down towards this area. So this is the actual pneumothorax lead point, and it's called lung point. And if you see this, that is 100% predictive that they have a pneumothorax. If you see lack of sliding, usually it means they have a pneumothorax, but there can be some scenarios that cause a lack of sliding. Like maybe you're looking on the left side and they have a right mainstem intubation. Maybe they're splinting their chest because they have a lot of pain, so you won't see chest movement if they really have a lot of splinting due to pain, or they've got adhesions or something else from prior surgery or scarring. So there are a few things that can cause a false positive on the lung sliding, but the lung point, there's almost nothing other than some things that mimic it, like if you catch the liver or the heart just edging up under the chest wall, they can look like a lung point. But if you see a true lung point where it's lung edge moving up and down with an area of no sliding, then that is pretty much 100% definitive diagnosis of pneumothorax. Then the next findings are going to be B lines. So B lines represent interstitial fluid, and the pattern and the distribution of the B lines in the chest will help you decide what's causing them. If you see them pretty much on both sides of the lungs and they're pretty symmetrically distributed and the pleural line is pretty clean, then that's probably pulmonary edema. There may be cardiogenic or non-cardiogenic pulmonary edema, but if you see symmetric B lines, that's probably pulmonary edema. If they're focal and they really are just concentrated in one area, or they kind of skip around, then that's probably an infectious or inflammatory process, and we usually think it's pneumonia, but it may be pneumonitis or something else. So symmetric B lines, pulmonary edema; asymmetric, focal, patchy, skipping around, infectious or inflammatory. And with pneumonia, you may see some other things where you see infiltrates actually dip out from the pleural line. So here, this darker area is an infiltrate. In this area, this whole lung, so this looks like liver, but it's not. This is lung. And all these white things in here, this is the air in the bronchi. These are the air bronchograms. So sometimes the lung is completely overtaken with atelectasis or infiltrate, and it will look like liver. So this is a very severe, probably pneumonia, and this is a smaller area of pneumonia, and there's B lines coming down all around it and from that area of infiltrate. So those are some even more specific findings for pneumonia. But you may just see focal B lines in one or two areas that are skipping around. Other examples, this rough, shredded area of lung is consistent with pneumonia. Same thing here. There's really deep, eaten out areas of the lung. This is consistent with pneumonia or other infectious inflammatory processes. Now, pleural effusion. Remember, pleural effusion is in the pleural space between the lung and the chest wall. And the best way to find this is from the sides. Find the diaphragm and then just look above. Here we see, if we see the spine going up, we know something's wrong. This is large pleural effusion. We see parts of the lung coming in and out. You can even see the thoracic aorta here. This is a complex, very nasty pleural effusion. This is probably an empyema. So, differentiate whether it's simple or complex, or if it's completely loculated like this, then that's going to affect how we're able to manage that and what our decisions are in the next steps. So, I know that was pretty quick, and that was a short overview, but just as reminders, some of the big important questions in shock: what's the physiology, obstructive or cardiogenic? And if it's neither of those, then we're probably going to give fluids and do some more workup. So we can usually figure that out with the heart and the IVC, and probably the lungs, depending on the scenario. And then if we think it looks like it's a hypovolemic or distributive source of shock, then we may look for sources of bleeding like an aortic aneurysm, or bleeding in the abdomen or chest. Or again, depending on the scenario, we may look at areas of the skin that look concerning. We may look for signs of a DVT. All this is driven by the clinical scenario, but ultrasound can help make us more accurate with our diagnoses, help us avoid errors, and make us much more efficient in defining the physiology and the etiology and managing the next steps. So that's really everything that we're going to talk about for now for the patient with shock and with echo and the lungs. See some of our other areas for some of the information about DVT and ruptured AAA and peritoneal fluid that you might see in trauma or bleeding or in a ruptured ectopic. And with that, I'll see you in the next round.